Hello everyone, I'm Karen Peterson, and today I'll be talking with the former Chief Executive Officer of the Twin Cities Medical Society, Sue Schettle. TCMS represents over 4,500 physicians, residents, and medical students in the 7-county area surrounding Minneapolis and St. Paul. Over the past decade, Sue has been instrumental in reimagining the role of the County Medical Society and positioning TCMS as a leader in advocating for public health. Today we'll be talking about how TCMS made that change and what Sue has learned throughout this process. Welcome, Sue.
Thank you.
I'd like you to start with just a general overview. How did the Twin Cities Medical Society, or TCMS, become involved in the realm of public health?
They decided to get into it about a decade or so ago, and they wanted to look for an issue that all physicians cared about. And so they decided at that point that working on population health issues is something that every physician cared about. And so they began to look for issues that fit that criteria. And at that time, there were a couple of initiatives that were going on, one of which was smoke-free public policy. Okay. And so they focused in on that, and then that started the journey for the Medical Society and for myself.
Now, I seem to recall that about the same time, there were also changes in membership, which was making medical societies start to look for new projects.
Right.
Was that the case with TCMS?
It was. Actually, when I was hired as CEO, one of the first things that was asked of me was to try to figure out a way that we could increase non-dues revenue. And so what that meant is getting more grants and getting more money that wasn't attributed to dues. And the reason why that was a focus is we were seeing a decline in membership. And some of our large healthcare systems were becoming larger by swallowing up some of our smaller independent clinics. And because of that, we as a medical society relied on those smaller clinics to be our members, and so we were seeing a decline. So we were looking for non-dues revenue opportunities.
So for those who may not be familiar with what public health entails, could you describe what public health means in the TCMS situation?
Yeah, it's really more looking at the health of the population. So it's not looking at one individual clinic, one individual patient-doctor relationship, or even one healthcare system. It's looking at the population as a whole, and that means that all of the healthcare systems are affected by it, not just one.
Could you give a specific example?
I think the smoke-free public policy is probably the best one. We looked at the physicians know the health impacts of smoking, and so trying to deal with it one-on-one with a patient was, sure, you make some progress there, but if you look at it from the population perspective, if you enact ordinances that affects everyone, then you're making a broad sweeping change.
So how do medical societies fit into that public health, population health?
You know, I've been in healthcare administration for a long time, and I think medical societies are uniquely suited because, when I look around the table at the board of directors, for example, and I think this is probably the same across the country, is that you've got leaders from all the healthcare systems sitting around your table. And so they're coming to you because we are sort of we serve a unique role. They come to us to advance our mission. And so I think county and a state medical association, we already have the people around the table that can affect change. And so it's easy for us to then take it to the next level. And we're also neutral turf. We don't treat patients, but we are an organization that can actually get things done.
So what public health topics has TCMS tackled?
Tobacco's been the big thing for a long time, and that tobacco means all kinds of things. It means enacting ordinances, it means working on menthol restrictions, which is something that we're working on currently, working on cessation tools, helping people to quit, is that the way you say it? And we're also have worked on prediabetes and obesity prevention. We've worked on an end-of-life care initiative called Honoring Choices Minnesota. So we've really had 4 or 5 or 6 really successful runs at public health.
Now, through this work, I understand that you've created a model. Mm-hmm. Now, is that something that other societies could potentially implement?
For sure. It's the Physician Advocacy Network. We call it the PAN. And this is an initiative that's really got 3 main components. We educate, empower, and engage physicians and medical students on public policy initiatives that are related to public health. So if you know, physicians are, and medical students, they obviously they're smart folks. They want to have the scientific information available to them, so we educate them on the topic. We empower them by giving them tools and resources to enact the public policy, and then they become our strongest advocates at the city council and wherever it is that we're working with elected officials.
So can you take what you just said in the abstract and make it concrete? Like take a tobacco issue. Mm-hmm. What specifically do each of these groups of people do?
Sure. So I'll go back to tobacco because that's been something we've worked on for a really long time. We identified people that were interested in, identified physicians and medical students that were interested in the topic of smoke-free public policy. We gathered them, trained them on how to speak to elected officials, for example. We gave them the scientific information that we had gathered along with our medical director, Dr. Pete Donnell, and he really trained them on how to be advocates. Then we worked with them to have them testify at city council hearings or even at the state legislature about what they've learned through the process, through the PAN. And then what we built there is actually lifelong advocates, because that's sort of the model. You just give them the tools and resources to enact public policy, and then they understand that they can replicate that for other public health priorities.
So how do you think physicians benefit from this work?
I think that well, personally, I know a number of them that I've worked with over time have told me that, you know, they never really have been asked to do this kind of thing before. And that once they had been involved in this level of public policy, it opened their eyes to the fact that they can, by their involvement, that they can enact sweeping public health changes. So I think that they personally can see the broader impact of being involved rather than just a one-on-one relationship with their patient. They can look at it more broadly.
And then on the flip side, how does the medical society benefit?
Well, they benefit a great deal, quite frankly. Again, when I started, we were looking for non-dues revenue. And what I saw as we began to look for funding to support our public health work, we were moved in a position from just being a player or, being someone that's at the table to actually being at the head of the table. So we were setting the stage for some of our healthcare partners to come around and partner with us. So we were viewed more as a leader in a way that we hadn't been previously. Our members found value because we actually, at the end of the day, could show that we moved the dial. We actually enacted ordinances, and we actually did things that happened within a shorter period of time than what we have traditionally seen in other things that we've worked on. And then we get non-dues revenue. So non-dues revenue is a really important thing for struggling county and state medical societies.
It sounds like this is really a win-win for physicians and the society.
Yep.
But I'm particularly interested in this non-dues revenue. Can you tell me more about that?
Yes. So non-dues revenue is basically it's money that comes into the society that isn't connected to individual dues. So when you join an organization, you have especially a medical society, individual physicians pay for their dues. Non-dues revenue means that we're getting money in from organizations, from grants, or from healthcare systems that aren't at the individual level, so they're at a corporation level. And so some examples of that, we've gotten grant dollars from health and human service organizations, from private foundations, but we've also gotten grants from those large healthcare systems that employ physicians that aren't traditionally members of the society. So.
Well, going to large health systems, that sounds like a big ask.
Yeah.
Is this something you've always been comfortable doing?
No, this is not. In fact, had I had the job description given to me that included the fact that I was going to have to ask for money, I would not have applied for the job because it's just not in my DNA. I'm not comfortable. I've gotten comfortable, actually. In the beginning, I was not. But what I did is I surrounded myself with people that were comfortable. We had a good idea. I knew that. But I just needed to be comfortable asking for money, and there are a lot of people out there that are comfortable in that space. So for a number of years, I knew what I was good at and what I wasn't good at. But the people that are out there are people out there that can really help with raising money.
And does that apply to grants as well?
You know, yes and no. I mean, the grant, it depends, right? So some of the grants that I've applied for have been super methodical, and you've got to jump through all the hoops, and you got to fill out all the forms properly. And other grants that we've applied for have been through conversations. So we've sat down and met with healthcare system leaders and say, you know, we have this great idea. We'd like funding for it, and so in some cases it was you know, an hour conversation, and we got the funding. So it really does, you know, kind of runs the gamut.
Now, I've heard from other people that grant writing specifically gets easier because you find you can use the same information in multiple situations.
Yes, I agree completely. Yeah, a lot of the grants ask the same thing over and over again, like, you know, things like you need your IRS determination letter, you need, you know, your 990s, you need your latest financials. That kind of thing is almost always asked by grants. So you can, and then also the description of your organization. You know, that's a good chunk of, and your ability to carry out public health priorities. Those things you could pretty much do a cut and paste.
Now, if you didn't have that skill set, have you ever worked with a professional grant writer?
Yeah, actually the very first grant we ever got way back in the day was someone we hired. And the second grant that I applied for, I copied what she wrote. And so that's sort of how I learned the game a little bit. But we did hire our very first grant writer.
Okay. Now, what kind of response? You mentioned that sometimes the grant process is an hour-long conversation.
Yeah.
So that implies that funders are receptive to your message.
Yeah.
Is that usually the case?
I don't think so. I think it boils down, I think it boils back to the goes back to what you asked of me earlier, and that is, what's the role of a county medical society and why are we successful? I think a medical society is a known entity in the healthcare marketplace. And so, and TCMS has built capacity and built a history that we can do this work. And so, and we've seen it. We've seen a number of things go forward because of the physician advocacy network model that we've created. So we have a track record. So some of the conversations that I've alluded to that were an hour long, those were with CEOs of healthcare systems, who knew us and knew that we'd be able to carry forward the work.
So building a strong reputation has benefited you.
Yep, for sure.
Wonderful. Now, obviously, this money that you're receiving is to fund a specific project, but are there other ways that the revenue can benefit the entire society?
Yeah, and actually that's been one of the reasons, that's been very helpful to the society in that, and to cut our overhead costs down. So with, where our office is, we have, it's sort of expandable for staffing, for offices and things, but we need to pay for that. The medical society can't absorb, costs of having new furniture and all that kind of thing. So the grants have really been helpful with the overhead and with actually paying for part of my salary or someone else's salary on staff.
So you mentioned staff. How big is the TCMS staff?
There are 9, and the majority of those are funded by public health grant dollars or contributions. So we'd be pretty lean if we didn't have grant dollars coming in.
So can you share with us over the last 10 years about how much money have you brought in?
It's been about $6 million. And I know that is a number that for an organization that's never raised money before, I know that seems like an insurmountable amount of money, and I know it's a lot of money, but I also know that county and state medical societies already have the clout, they already have the things that other unknown entities don't have. So and so I wouldn't, I don't want people to feel as though that they couldn't possibly raise that kind of money. It's out there, and you just have to have the people surrounded with you that can ask for money. And this has been 10 years. So this has been a long haul. There have been a couple of years where we didn't get anything. And then there have been other years we've gotten quite a bit. So.
Interesting. Now, sometimes the question comes up as to whether or not it's a good idea or an effective strategy to have multiple societies working together.
Yeah.
What would you say to that?
Well, a county and a state society, especially in Minnesota, how our situation is in that we are like literally in the same building as our state association. And so I think that it's important to have a conversation with other medical associations, whether it's your state or your county colleagues, to see how this project will unfold. What we did at TCMS is we partnered with our other county medical societies from across the state, because what we were trying to do is embolden them and strengthen them, because they too were struggling with non-dues revenue issues. My advice to organizations that are starting out new with a new grant, and if they're a county, to go to the state straight up and say, here, we've gotten a grant, or we want to get a grant, we want you to be a key partner, so that you're not competing for dollars down the road. Because this public health model is, it's successful, and when there's a lot of money out there, you can see where it can be competitive. And so you don't want your other county or your other state, or the state association competing with dollars.
That makes a lot of sense. There's only so much to go around. You want to manage it well.
Yep.
So if another organization watching this video would be interested in developing a model, something like what TCMS has done, what advice would you offer?
Don't reinvent the wheel. You know, we truly have resources that can be available to other county and state medical associations. We have a toolkit. We have, information that we can just send your way. And I think that, and the other thing is, ensure that whatever it is that you're going to be doing as a medical society aligns with your mission and vision. It's easier to get grants that way. It's easier to get your membership around the issue because they've already prioritized it as something that they care about. And then making sure that you have a physician champion. I learned early on that as a medical society exec, you can't get too far ahead of your board, and you can't get too far ahead on issues. It's best, the biggest clout that we have as a medical society is that physicians are a known entity in terms of when they speak at the legislature, when they're involved in topics, they generally get a higher level of interest, because physicians generally don't show up to things like that. And so that's our clout, and that we should continue to use it.
So you mentioned the importance of having what you called a physician champion. Mm-hmm. As you've developed these projects and worked in the public health arena, have you noticed differences in how your physician members feel about their work?
Yeah, and I've also noticed how what they've done with us has affected them personally. So I'll give you a story of there was a physician who was a medical student. This is back when we were working on smoke-free public policy. I'd never had an interaction with him before. Sent out an email to a bunch of people, and he responded and said that he would testify at the city council hearing. And then he went to the county and he testified at the county. And then, 4 or 5 years later, he's serving on the Twin Cities Medical Society board. And he's likely to move up the chain of positions that we have. But he told me recently that his interaction with the Twin Cities Medical Society changed his perspective on his role as a physician. So rather than being just someone that would, just treat, again, just one patient at a time, he began to look at the population from a different lens. And it was because of his involvement in the work that we're doing at the Medical Society. I've heard that story multiple times. And I also know that the medical director that we've got on board, Dr. Donnell, has trained hundreds of physicians and medical students on how to be advocates. So that goes a long way, I think, to changing not only the individual physician, but changing the population.
So you actually have physicians training other physicians?
For sure. Through the Physician Advocacy Network, one component of it is educating. And so Dr. Donnell and I have been working together on this for a long time, and he's built a network of physicians that can train other physicians as well, just by having gone through the program that we've created.
And it's wonderful to hear stories like the one you shared, where a doctor really does change their outlook based on this type of work.
Yeah.
So now thinking back to 10 years ago, you already mentioned that if you had known you had to fundraise, you might have had second thoughts.
Yeah.
What else do you wish you would have known back then that you know now?
This is more on the, I guess it's the fact that I didn't realize at the time what an effect the work that we were doing would have on the population. I know that seems kind of light and fluffy, but it's also, when I look back at my career and look at the things that we've done as a very small organization, doing big things. And so to know that we were centrally involved in the smoke-free movement in the state of Minnesota, not only does that affect me personally, but the membership that were really involved at that time. You remember that too. It's just a big fundamental change in the population health in Minnesota. So,
well, thank you very much for taking the time to talk with us. It's been wonderful to hear about the successes that you've had leading the TCMS, and we appreciate your time.
Thanks for having me.